Welcome back, everybody, to the Sports Medicine Project, Part 2 with Dr. Jai Kumar. My name's Blake. I'm with my co-host, Kelly Kortic, physio, about to be a sub-320 marathoner come 8 weeks.
320?
Isn't that what you're aiming for?
You're more optimistic than I am.
What are you aiming for?
330.
330. About to be a sub-330 marathoner.
But,
Yes.
as you say that, I feel like I need to I need to stop saying that I'm aiming for this goal that's, I know is going to be, that's a bit of a challenge, because anytime I mark a race as like an A race,
Yeah.
I just don't do well. So
You think you're setting yourself up for fail?
Maybe.
Oh, yeah.
Maybe I need to start thinking about it as like a B race, or just like, I just want to do it. I don't really care what time I do. Because anytime, I set the expectation too high, I don't sleep the night before, and I've just got that like nervous anxiousness the whole night, and then it just goes to shit.
Yeah, so you would say your expectation perhaps is a little bit different to what you want to do compared to what you think may happen. No, they're the two same things. Your expectation is going to be different to what actually happens, and the bigger that divide, the worse you're going to feel. Do you think?
I don't know. I don't really know what you mean by that, but races where I have low expectations, I do a lot better than races where I have high expectations.
And why do you think that is?
I think I have less pressure. It's less pressure.
Okay.
It's probably a mindset thing that I need to work through. But any tips,
I don't have any tips for that. But given this is a show as health professionals, how does that, or for health professionals, how would that relate? We think about the expectation, that people have with their injuries and with their pain and coming to see us, where I do think that is one of the reasons why people, there is certainly many, one of the reasons why people don't come back. Perhaps they cancel, or they self-discharge, or, they perhaps disappointed, is because their expectation wasn't set from the start. And, we know, for an example, a tendon might take a long time to get better. If they're expecting it to be better in a couple of months and it's not, and you haven't kind of front-loaded and given the education, that can be difficult for someone to grasp. So perhaps that's the reason why. Like, I thought it would be better in 2 months and no one told me otherwise, and that's why I'm going to go and see someone else.
Yes, I do get that. However, in this scenario, I don't think I've set myself an unreasonable goal. I think it is a goal that I can achieve. It's just the fact that I'm looking at this as like a big marathon of the year, and I don't know.
Yeah, okay.
Open to advice though.
Yeah, I'm not going to give any advice. That's not my area.
Not your area?
No, not at all. Not at all. I actually had someone this week, talking back to kind of patient expectations and more clinical, where, and I do have it happen now and then, and I know, and we say this all the time, I know it happens to myself, and I'm sure it happens to you as well. You're not going to be everything to everyone, and people will self-discharge, people will go somewhere else, and that's just kind of part of being a health practitioner. I was thinking how I would posture this and how I would say that, and I can straight away see what the criticism is you get too comfortable. That's not a good way to think about it. If you're like, I don't care if people go somewhere else, and I'm certainly not saying that. What I'm saying is the long-term goal is the more you can minimize how much that happens, that's a good goal to work towards. I haven't seen it done, but I just don't think you can ever have 100% successful outcomes from a patient's point of view. So if you ask every single patient that you've seen, you might think, it's successful, they got back to sport. But for them it might be, they got back to sport, but it feels the exact same as last time. So they wouldn't say it's 100% success, or that's exactly what I wanted. I just don't think you can have that. And you can beat yourself up about it, of course, which is kind of good, but kind of not good, because that's something that you need to work on, because you need to try and minimize it. But it's hard to not take that personally.
Well, at the moment, one of the Ripon projects that I'm involved in is looking into patients' perspectives on what they perceive as high-value care.
Yeah.
And there's a lot of it, the stuff that's out there currently is, it doesn't quite answer that specific sort of question, but a lot of it's about sort of communication between the therapist and the patient. That's the biggest thing that patients are sort of looking for. But then when it comes down to like the diagnostic side of things, the skill side of things, what they're getting out of the treatment, there's not really huge amounts of literature out there. So it'd be interesting to sort of see what that looks like. I also had a similar sort of question for you today. When patients sort of tell you that they're happy to self-manage a problem, or like they maybe say they're like 80% or 70% and they've been making good progress and you can see that they're, you know, heading in the right direction and sort of doing the right thing, and they're happy to sort of step away from what you're providing them with and try and do the rest of it themselves. Maybe if they've got a bit of an understanding about strength and conditioning, or have an understanding about you know, how to appropriately progress their exercises because they've been down that track before. What are you doing in that situation? Are you just letting them go, or are you advising against it, or are you asking them why they think they can, or what do you do in that situation?
Well, it's ultimately their decision, and I usually I talk through everything that we've done from the start. What was the initial goal when I very first saw you, all the things that we've done, and ask them, do they have a good understanding of kind of what's happening and what needs to happen, and then just asking them, do they feel as though they can self-manage, because it comes down to, I guess, of course, their preference, but also your confidence in them to be able to self-manage. So if you're afraid, as an example, that they may, you know, go out and spend all this time on their feet, or they go for a really big run when they're perhaps not ready to, and basically just boom and bust, you know, dictating that to them and explaining this is perhaps some evidence that you've done this in the past, and, you know, we want to try and manage it as best we can. This is why I think, you know, we should catch up in a couple of months, or catch up in 6 weeks, or, you know, if we don't want to do that, I can just check in with a text message in 6 weeks, or here's my email, just send me an email if you have any questions, or trying to teach them the way to think about when it's appropriate to come back and see me. So as an example from someone from this week who we'd managed with Achilles tendinopathy, going really well now, back to everything, and an older gentleman, he just wants to be back walking on the treadmill 6 kilometres uphill every day. Back doing that, he's got a 1 out of 10, but it's trending in the right direction. All the rehab, and quite a really smart guy, and he's like, I feel as though I know everything that I need to know for this. I'm like, great. This is when you need to come back and see me. If it regresses for 3 days where it really flares up and it's sore, you can't spend time on your feet like you used to, and that stays consistent, and, you know, the flare-up lasts a longer time. And yeah, I'd rather them just reach out than not, and I can either give them a call or an email, or I can see them again and kind of say whether it needs to be continued, that we go down another treatment journey, or, you know, you're okay to keep managing on your own.
And which sort of cases would you be recommending against self-managing and encouraging them to continue to see you, or would you not?
Which conditions? I guess the ones that are the higher risk, where there's a disproportionate, if you look at pain and then the proportionability, I don't know if that's a word, to the severity of the injury. So if you have tendon pain, that's okay generally, if you can manage it and push through and it settles down and all the things that we know about tendons. But, you know, if you have a bone stress injury and your second metatarsal and you're starting to get a 2 or 3 out of 10, you know, I need to see you again, because we need to, you know, possibly rescan, perhaps go back and do a boot, perhaps look at your overall volume. Did you go back too quick? Are there other factors influencing it? So I always try and indicate the severity of a condition, where, you know, tendons are a little bit of a grey area, I say, where, you know, a little bit of pain is okay and you can generally manage, and you might just need to take a couple of days off. And I guess it is somewhat similar with bone injuries, but the amount I'm dictating the severity is different from tendons to bones because of, you know, the potential consequences of that.
Yeah, good answer.
Yeah, what do you say, or what do you do?
I agree with you. I had a situation with that, or something similar to that this week, with a patient who has a background in healthcare, and they were sort of happy to self-manage their rehab moving forwards, and it was a conversation that I was having with them about, you know, if they feel like they're not making progress, or if they need some extra assistance with, you know, rehab progression, to come on in, because that's something that I'm more than happy to help with, even if it's just sort of taking it out of their own hands, so that they've got that sort of objective direction that's not influenced by emotion and feeling and everything else that comes along with with injury. But yeah, it certainly got me thinking, you know, when are you more inclined to sort of push for them to come in, and when are you sort of happy for them to try and manage it themselves? In that case, with that particular injury, I was trying to sway them to come back in to see me, but it didn't work. They were just really happy to try and manage it themselves for the moment. So I just, exactly what you said, gave them, you know, my contact details so that if they do need to come back in or to have that reviewed at any point, then they know where to reach out to.
Yeah, it's difficult because, you know, you almost are, we've talked about this before, you're always trying to help someone think about their own injury, but in a sense you are manipulating them because you want them to understand the severity of what's happening, and above all else, you know, you don't want things to get worse, you don't want them to regress. You know, if you've gone through an injury yourself and you know how much it sucks, you're like, we want to try and manage it as appropriate as we can. These are the reasons why I think it's good that I should still see you, and this is what we would do, and these are the potential consequences if not. And in reality, of course, it's their decision, as long as you're comfortable and confident that they know how to think about it, and they know, great, Blake or Kelly said, if I've got pain here and it hasn't settled in 3 days and I've reduced my training load to this amount and it still hasn't settled, I need to book back in. And that can be hard because you give a lot of people a lot of information, and sometimes it might be better just to send out an email. And I've done that before in the consult where we've gone through everything, we've got plenty of time. Like, great, I'm just going to send you an email and saying these are the things where it might be more appropriate to come back and see me. Certainly doesn't guarantee that you have to, but I think it would be more appropriate. And yeah, that's worked okay. And then it depends on the archetype of the person, like their personality. Are they a person that at the drop of a hat come back in straight away, or are they like, no, I just wanted to push and see how it went for 6 months and it didn't improve?
Yeah. That's so classic. Hey, you can certainly think about those patients who just they end up in your diary regularly just to check in on and those little niggles that have popped up, and it's and then there's the opposite, as you said, the patient who's been, you know, pushing through or enduring this problem for a long time before deciding that they're going to come in and seek advice for it.
I found that the hardest thing, I still find it, you know, hard, not as hard, but I found that the hardest thing as a health practitioner, you know, we hear about KPIs and PVAs, the patient visit average, and how often should you be seeing someone, and there's one camp that says, you know, seeing them lots and lots is better because you can reinforce the education, you have a better relationship with them, perhaps they're more trusting. And then the other camp's like, no, if you're really good at if you're really good at giving them education, teach them how to think, and you give them lots of resources, they should be able to self-manage on their own. And then there's everybody in the middle. It's challenging because you don't want to overservice someone, but you certainly don't want to underservice someone. And I guess what are the risks?
And what is that sweet spot?
Yeah, and what are the cons of both? I mean, what's the kind of underservicing someone is, you know, they might go somewhere else, the injury regresses, perhaps they might have pain for longer, I don't know. But then overservicing, you're just seeing someone that you perhaps don't need to see that often. And, you know, is that ethical, unethical, cost more, that kind of thing.
Yeah,
what do you think?
And then this is what this project is going to be about as well with Connor and through Ripon is, you know, if the patient doesn't feel as though you're over-servicing them and you're giving them useful information and answering their question and reassuring them and validating their pain and their symptoms, then that's not over-servicing, even though you may not feel like it's totally necessary. But then in the reverse, you might not see the need for them to be in there.
Yeah. Now I'm going to hit you with a question.
Yeah, go.
How do you know if the patient feels that way? Do you blatantly ask and say, hey, do you feel like I'm over-servicing you because I want to see you twice next week?
I have no idea.
Is there a way to evaluate other than, I guess asking them, but that would be a pretty hard question to ask, I guess.
I guess it's kind of comes down to in that scenario where it is almost more like a monitoring type of session.
Yeah.
If they're getting to the end of that session and they're sort of asking, you know, when they can book in, when's the next 6 month or 6 week check-up, just to come in and make sure that they're heading in the right direction.
Pop in for a tune-up for a service.
Well, if they find value in that, then I guess there's nothing wrong with it. And if it's allowing them to do what they want to be able to do and just getting those little snippets of information from you and being able to, you know, contemplate their pain and their symptoms and have that appointment that they're looking forward to keep them accountable with their exercise and that behavioural change things, then I think that's validated.
Okay. The question that comes up for me when people say that, and in this context now, is if they believe it's good for them and it helps them do all the things that they want to be able to do, I understand that's great. Is that because of us as practitioners, we haven't given them the right strategies to be able to do that? Or is it just inevitable that a certain percentage of the population need that and always will? And it's these certain subgroups where, yes, there's a case where you probably don't need to see someone if you're really on point maybe with your education and strategies and that kind of thing. But there are some people that, regardless of the best advice in the world, will just do better coming back to see you regularly. Oh, not regularly, but 6 monthly, annually, a couple of times a year. Because I have people like that go to, I'm going to say, and I don't mind saying it, I don't see it with physio or podiatry so much. I see it, patients tell me that they might be seeing their chiropractor a couple of times a week. And this is nothing against chiropractic or anything like that, but I just hear that more from patients. And some of them say they feel so much better after it and they can go out and do all the things that they enjoy. So, there is no right or wrong, but I guess...
There's a grey area.
Yeah. But do you sometimes do think, and maybe I'm the only one that thinks that, is it really necessary? Or is there a reliance there? Is it dependence there?
I think there's an archetype of people that are going to do well with regular reassurance.
Yeah.
And then there's an archetype of people that will just cancel the booking and decide that they are okay without you.
And then they book back in like
choice.
6 months later. Yeah. And you think, why didn't you tell me you were fine? I always say now, jokingly, it's great if we get to 3 months down the track and you're doing really well and everything's fine. I'm just going to put it in the diary. I'm going to put this text message there and it'll go out, automatically. If everything's fine, just please let me know. And I look at them and kind of joke, please let me know everything's okay, because I don't, I'll be worrying and thinking something's happened, especially with heel pain or a tendon or something like that. Yeah. But let's leave it there for these listeners, and we'll talk to you all next week. What would you say, and I'm in the clear here because I'm a podiatrist, so I don't ever see any ACLs, and if I am, they're straight out the door to go and see physio orthopedics. But what would your, I guess, from what you just said, as a young clinician listening to this who hasn't seen many ACLs, what advice, I guess, would you give them? And I guess it's based off what you said, keeping your correspondence and relationship, as best as you can, but what kind of, not mistakes, but what things do you see that could be done better, generally? And I guess, how could young clinicians avoid those?
Yeah, so if your index of suspicion for an acute injury of the knee is there, and as it whether you're a new grad physio or 10 years out, you have an index of suspicion for an injury. If you have an acute instability episode, there's been swelling after the injury, you've got swelling under control, and you have concerns about a ligament, meniscus, or that kind of thing. MRIs are so readily available now, and they're becoming more and more available. And through a GP, an acute knee injury can generally be, an MRI can be organised by a GP. I organise MRIs for physiotherapists all the time directly. If I know them, they'll text me and say, I've got this patient with this injury, can I have an MRI? And I send them a form for an MRI. An MRI gives you a structural and objective explanation of what you think is going on clinically. Now, once you've got that, then you've got, in essence, the answer to whether they need specialist help or not. So what my advice to clinicians would be is, if your gut tells you there's an injury, a ligament injury or an ACL or that kind of thing, and a GP might be saying, let's get an X-ray or an ultrasound, and you feel a patient needs an MRI, don't be afraid to back yourself and go, this patient needs an MRI. And there's enough knee surgeons around Newcastle that will gladly organise an MRI for you if needed. And the majority of GPs now are more than happy to organise an MRI if a physio's index of suspicion is high. Because if you get an acutely injured knee, it doesn't matter how experienced you are. It's quite hard to determine whether someone's got a grade 3 Lockman test or whether they've got positive McMurray's test. And a lot of their clinical tests as much as I hate to say it, sensitivity and specificity high.
It's kind of an ACL rupture, like a traumatic knee injury with a big knee effusion is an ACL until proven otherwise, really, isn't it?
Absolutely. And if it's a 15-year-old with a loose osteochondral fragment and we pick it up early, it's potentially fixable. If it's a bucket handle tear of meniscus, the sooner we get it repaired, the better it is. So I think my advice to young clinicians is back yourself and back your clinical acumen, because you've done the training. The majority of physios have some kind of connection with sport or activity, and the only way you really, I guess, get confidence in these areas is to put yourself out there and back yourself. And I think the majority of so I'm just charging my phone up. The majority of surgeons will appreciate your forwardness and willingness to be actively involved in the patient rather than sort of sit on your hands. So that'd be my biggest thing. And as much as I guess an older generation of surgeons might say, an MRI just gives it, aside from putting a camera in a knee, it's the gold standard of investigation. And we often have the luxury of seeing an ACL. The ACLs that I get referred to acutely, generally a physio will call me and say, I've got an ACL rupture, had an MRI, and I'll say, right, I'll make an appointment in 4 weeks' time, start prehab. I want a calm knee, 90% quad strength, pain-free range of motion. And by the time I see them back 4 weeks after the injury, they've got that essentially prehabilitated knee, and you're having a discussion with the patient about, okay, let's talk about operative versus non-operative management. And I get to examine a knee where the Lockman is obvious to see, but if you get them on the field or 2 days after their injury, it's going to be really hard to determine that.
Yeah. Question about a lateral loop. I feel like I see a lot of younger patients that end up having a lateral loop done. Is that just purely based off age, or is that instability, or what's the decision making around?
Yeah. Can you explain what a lateral loop is for a young foot lover down here that doesn't see many knees?
So it's interesting. What Kel's talking about is that over the last few years, there's been a move towards augmenting an ACL reconstruction with something called an extra-articular loop or an extra-articular augmentation. They're variations of a theme, but essentially what we're trying to do is create an extra seatbelt on the lateral side of the knee to help protect an ACL reconstruction. And the two most common ones we do at the moment are called a modified Lemaire or an Ellison procedure. And essentially what it's doing is taking a central slip of the iliotibial band and passing it under the lateral collateral ligament and reattaching it, or putting a loop around the lateral collateral ligament. The best way to do it, ironically, historically, that used to be, before we knew how to do an ACL reconstruction inside the knee, that was what we used to do for primary ACL reconstruction. We do this loop on the outside of the knee. Since we've started doing these, we've found that they reduce the rate of re-rupture, and probably halve the rate of re-rupture. So I usually say to my patients, the likelihood of re-rupture of an ACL in a primary knee is around 10%. Some people say 14%. If you have an extra-articular loop, it drops to closer to 5%. But it's another operation. It's an extra bit on the side. It's an involved procedure. Some surgeons do it, some surgeons don't. My indications for doing it are any revision ACL reconstruction, I'll do it. I'll do it for my pivoting collision athletes. I'll do it for my hyperlax patients. I'll do it for patients that have quite significant instability, so a very obvious pivot shift on the table. And a lot of patients, what I'll actually do is say, I'm going to do a standard ACL reconstruction. I'll write plus or minus extra-articular augmentation. And I'll say to them, I'll do the ACL reconstruction. I'll assess you on the table while you're asleep. And if I need to do that extra loop, I'll do that for you. And what that means is an extra cut around 7 to 8 centimeters long on the side of the knee. It doesn't change the rehab protocol at all. The patient isn't braced afterwards. It doesn't slow down, it doesn't speed up or slow down the return to sport. But what it actually does is reduce the re-rupture rate.
Is there an argument that should be done every time? Like what are the issues, complications with it? Like if it's halving the re-rupture rate?
Well, so whenever you do a reconstruction using a graft, an autograft, so a graft from someone, you've got to remember you're taking normal anatomy from somewhere to put somewhere else. So you're robbing Peter to pay Paul. So if you take the central slip of someone's ITB and then stitch it up together, there's increased swelling, pain. You potentially tighten lateral collateral ligament, tighten the ITB. When you pass the ITB under the LCL and attach it, if you attach it too tight, you can actually cause some increased external rotation force on the tibia, but also there's concerns whether you increase the load through the lateral compartment, which can lead potentially to early arthritis. And that's really a controversial area at the moment, an area that we're in pretty heavy discussion about. So there is a concern with doing a lateral loop that you might over tension or over tighten that lateral compartment. The way we usually fix it, the way I fix it, I usually keep the foot in neutral rotation and around 10 or 15 degrees of flexion. And what you find is when it's designed to, and Kel, you've obviously know what a pivot shift test is. What it's designed to do is help stop the lateral femoral condyle subluxing off the back of the tibia. And the best way to describe it to a patient, it's like having an extra seat belt over your ACL reconstruction. In that area of the body, you've got to pass the ligament under the LCL, and I've seen the LCL cut before as part of that process. I've seen common peroneal nerve injuries, which are a disaster, and it's not a fun part of the knee to be in. And if you're going to be there, you want to have a good reason for being there. And there's increased risk of neurovascular injury, bleeding, hematoma, all those kind of things that come with it. So that's it. There may be a point at some stage where we're doing it for all ACLs. And the other thing is some people just don't like the extra scar.
Yeah, it is a bigger one, isn't it?
So how do you get the tension? Is about putting it in the position you said, foot neutral, knee, and then you check.
So it's interesting you ask that, because it comes down to the kind of extra articular augmentation you do. So I started doing something called a modified Lemaire, and that is where we take a central slip of the iliotibial band, about 1 centimetre wide. We detach it proximally. So you leave it attached to Gerdy's tubercle, which is sort of anterolateral aspect of the tibia. We pass that under the lateral collateral ligament and anchor it into the side of the femur, so just behind the insertion of the LCL.
That's crazy.
Now that's the procedure. The challenge is that around that area is where your femoral tunnel of your ACL is. So there's a risk that you can get tunnel convergence, and you do an ACL reconstruction, then you do your loop, and you trash your ACL reconstruction by drilling your loop through your ACL reconstruction. So, and that's happened in the past, and it's one of those things, if it happens, then all of a sudden your carefully planned ACL reconstruction is ripped apart, and you've got to go back to it again. The one I'm using now, and this is something I've moved to in the last 3 or 4 months, is something called an Ellison procedure. And that's where we take the same central slip of ITB, but we detach it distally off Gerdy's tubercle, and we pass it under the LCL, bring it forward and reattach it back onto Gerdy's tubercle. So in the same position. Now, the advantage of that is, number one, and the biggest advantage is you don't risk tunnel convergence with your ACL, which is attractive. You're not dissecting down through the lateral aspect of the femur, where there's a loop of blood vessels there, there's muscle and all that kind of thing. But most importantly, you're anchoring the ITB back onto the same footprint that you took it off. So the decision about tensioning has been made for you, and it's that whole thing of reducing variables.
Yeah.
So the point you make is a very, very good one. It's quite an arbitrary decision. How tight do you make the LC? How tight do you make the loop? Do you leave it in neutral rotation, internal external rotation? What degree of flexion? Is that determined by whether the ACL reconstruction is isometric? Is it determined by what kind of fixation you use for your ACL? What graft choice? All those kind of things. So I now use an Ellison technique, which is just heaven, because it just reduces variables for me. And when you look back on historical extra-articular loops, they used to fix the Ellison with something called a Richards staple, which you often, if you look at the x-rays of ACLs up until around 6 weeks ago, when the company stopped making Richards staples, you could see this big ugly staple that was jammed into someone's tibia, and that used to hold the ITB or the Ellison procedure in position on Gerdy's tubercle. And Goose tubercle is a very, I guess, subcutaneous point. But you can palpate it there quite easily, and you can imagine having a staple there.
Yeah.
Bloody uncomfortable, especially if you kneel on it. Now, with the advent of all suture anchors and anchors we use for rotator cuff surgery, we just drop an anchor in there, and when you get an X-ray, you wouldn't even know that something's happened there. It's all sort of flat and not proud, and that doesn't bother the patient at all.
That's
So
so
it's
cool. That's awesome.
yeah,
Just the nuances of the surgery. It's just incredible.
Yeah.
I mean,
And
you hear about it explained so simply, like, yeah, you do this and do that. When you read about it or hear someone talk about it in social media, but to hear someone that actually does it talk about it, all the nuances of it, it's not just this simple little here and there, and there's no other risks associated with it.
well,
And
so, yeah.
No, sorry, I was just thinking, like, I mean, there's so much that goes into reinforcing the stability of the ACL with everything that you just spoke about. And I was just thinking, you know, the new thing which we mentioned prior in the podcast is the cross bracing protocol.
Yeah.
How much stability comes with healing an ACL opposed to a graft or reinforcing with the IT band.
Yeah, so
keen to talk about that.
It's interesting. I knew I was doing this podcast, so I spoke to Tom Cross on Monday night about this.
Wow.
So, and he's an amazing man, and as you know, he's the son of Merv Cross, who's probably one of the godfathers of knee surgery in Australia, and someone that as a knee surgeon we sort of get to stand on his shoulders as knee surgeons every day. So it was a privilege to talk to Tom, and as you probably saw, an article came out in the Sydney Morning Herald last week about cross bracing, and it's a very, very exciting and fascinating area of ACL injuries. But when you talk to Tom about it, he said, "Look, we're still working on this, and the study's in play, and there's a lot of work still to do before we are able to reliably say this is a way forward." And the challenge for him, I think, is that he's working on inclusion and exclusion criteria and trying to come up with an appropriate way of appropriately treating patients non-operatively with cross bracing. When that kind of opportunity comes to a paper like the Sydney Morning Herald, then the challenge for Tom is that everyone sees a ruptured ACL and thinks that it can be treated with cross bracing. So he's got situations where he's got physios bracing patients at 90 degrees for 4 weeks, but not putting them on anticoagulants, and all of a sudden the rate of DVT go up. When you talk to him about it, it is, as a surgeon, it's really exciting because we've got more ACLs than we can do, and then the incidence is probably going to get more and more. And when you talk to him about it, his aim really was to try and reduce the number of ACLs done, not to take them away from the surgeons, but to actually treat ACLs in populations where you don't have the luxury of surgery. So the uninsured population, Pacific Island populations, out west, or people are waiting on a waiting list. I don't want to get too much into the nuances of it because I don't want people to go off and go off reservation and undermine what Tom is doing. But what Tom explained to me, and it made perfect sense, he said, you need 3 things to appropriately utilize a cross bracing protocol. You need a clinician, so you need a doctor of some kind. You need
when you say clinician, you mean like sports physician, orthopedic surgeon. You don't mean just physio, or that's what?
No, so it has to be someone who can manage the risk of thromboprophylaxis. So you need to have a chart. So every one of his patients gets locked for the first 4 weeks at 90 degrees of flexion. That immobilizes a patient, and the patient has to go on some form of anticoagulation or thromboprophylaxis, whether that be Clexane, Apixaban, Rivaroxaban, those kind of things. That has to be prescribed by a medical practitioner, and that medical practitioner has to discuss the risks and benefits of anticoagulation, look into the patient's past medical history, make sure it's appropriate and it's not contraindicated. And that's a real challenge. There has to be a physical therapist who's aware of the rehabilitation protocol. So it's usually 90 degrees flexion and then unlocked consistently up until they get to about full extension around 8 weeks. And probably the hardest thing and most challenging things is getting the right radiologist involved. So this is a radiographic diagnosis based on specific slices of an MRI read by someone who knows exactly what they're doing. And it's to the point where Tom's now looking at the distance between the ends of the stump of the ACL, whether any of the ACL has been moved out of the notch, whether there are any other associated injuries. So there's all these different rules and, I guess, regulations Tom is looking at. And what he wants to be able to do is to create a situation where a radiologist who's experienced can look at an MRI and go, by definition, this patient's MRI fits the criteria that is appropriate for a cross-bracing protocol. And then that clinician, that doctor, can go, right, I've explained to the patient what's involved in this protocol. We're going to appropriately anticoagulate them. Then we've got an appropriate physical therapist that can manage the rehab protocol. And then we can follow this all the way through. And because the data is still in play on re-rupture rate, likelihood of healing and stuff like that, it's a big call to put someone in a brace and put them through, say, a 3-month non-operative management protocol only to find out their ACL hasn't healed. It's like this whole same thing that we talk about with non-operative ACL management. Someone's got to take responsibility for that. And I think I personally, talking to Tom about it, I want to make sure that his protocol gets the appropriate airtime at the right time in the right circumstances. And the fear with exciting things like this is that it's fantastic for a lot of people. There are people out there who don't want the cross-bracing protocol to their success because it potentially undermines their practice. And there is the risk that I don't want to see Tom's hard work, and this has been 4 years of his life, be jeopardized because people are going outside his recommendations and potentially creating a situation where people can go, oh, this never worked, it was never going to work. I believe it'll work. I don't know whether we've got the data yet on what the definition of a healed ACL is, whether it grows back as an ACL, whether it's scar tissue, whether it's a neo ACL or what. Tom has actually got an interesting website which I can point you all to.
Yeah.
It's healacl.com, so HEALACL.com. You might have to check that, Blake, and just make sure it pops up.
Yeah, I'm on that right now.
Yeah. And that's probably when you talk to Tom, just because he's one man, and you can imagine since that article went, he's so busy and so under the pump that he's getting calls from Europe and Japan and all over the place. And so the poor guy needs
constantly on the phone, this guy.
Yeah, absolutely. So he sort of said, look, this website actually gives people insight into where we're at with things. In Newcastle itself, there's a core group of physios and a couple of sports physicians that are looking at trying to emulate what Tom is doing, and that's very much its infant stages. And again, because we don't want to have a glut of people coming in with ACLs that are blown up that we're never going to heal, going through a cross-bracing protocol, and then 3 months later going, well, it didn't work, this is a joke, because it clearly isn't.
Yeah. What would you say, I like, for someone listening to this, and based off what you said, what they need, if somebody comes in and they said, I've heard about this cross-bracing, I want to get it, I haven't had my MRI, or I have had my MRI, how would you, I guess, have a clinician explain it to them if they get that question? And who do you think is best in their referral pathway? Is it orthopedics or sports doctor? I'd imagine maybe not GP, or like they need to be the people to have the conversation, not the physio.
Also, probably the biggest thing, and this obviously puts paid to a lot of people, is that when I spoke to Tom about timeframes, it's not the kind of thing you've got to get these patients acutely. So his absolute deadline was, if the patient's beyond 20 days after their injury, they're not going to heal. Closer to 14 days is better. So the ability of a patient to unfortunately have an injury, have a provisional diagnosis, get an MRI, get in front of the appropriate person in a timely manner, it is quite challenging. So there's a lot of patients that just simply will miss out in that time frame. my advice at the moment would be that Tom's got between 350 and 400 patients in a trial at the moment, and we're still waiting for data from it. And I guess as doctors, we work with evidence. So we sort of go, well, if this was my mum or my dad, what would I do in this situation? And when patients come to me with ACL, they want to know what their likelihood of success and what their likelihood of failure is. We're not really sure at the moment. And so if a patient wants to head down that pathway, they can. I know that Tom's shockers and is struggling. I know the sports physicians here in town are busy as anything as well. As surgeons, we're under the pump as well. I'm not convinced we're quite ready in our community here to appropriately manage cross bracing on a community-wide level.
Yeah.
Because I think it's not giving Tom's study the respect it deserves. Because I would rather him come to us or me go to him and go, mate, where are we at with this? And he goes, this is what we need to know. Bang, 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 bang. And this is our likelihood of success. This is what you can tell your patients, and this is what their risk profile is, and this is what the timeframes are. That gives patients some degree of I guess guidance. And the challenge when it's out in the mainstream media is that there's a lot of information. There's not the substance that you get from when you sit across from Tom Cross.
Yeah,
if that makes sense.
Yeah.
So I'd be more inclined to say it's exciting. It's a work in progress. We don't really have the evidence yet for it, and it is evolving. I'd probably recommend one of the sports physicians, but for me, I wouldn't feel comfortable putting someone in a cross bracing protocol because I don't have the expertise or the knowledge to appropriately manage those patients. I've had the luxury and the privilege of talking to Tom for an hour on Monday night, and that's probably 99% more than most of the population that are contemplating doing this. And from talking to him, it's clear that it's exciting, but the poor guy's working so bloody hard at the moment and doing such a fantastic job and trying to run a high quality study that if he's getting phone calls from Newcastle saying, I want to see Tom Cross about my ruptured ACL, and by the way, it happened 10 days ago, I don't want to see him within 4 days. It's
tough.
square peg in a round hole.
Yeah, it's incredible this stuff that comes out, and then just as always, it just gets taken so far from just this one idea. And like you said, the study had only come out 2 weeks ago, being published, and yet we've got all this. People seem to have all this information. It's like, how can you have that if the study's only been out for 2 weeks and we haven't even got any long-term data or to really know?
Yeah, well, I think the biggest thing is that often great ideas and great concepts get ruined before they have the opportunity to reach maturity. And this is one of those very specific situations where if we get it right and we get the right data, it has the potential to have a profound impact on the management of ACLs, not only in a first world country like Australia, but in countries where they don't have ACL reconstruction. And if we can get a healing rate of 50% on ACLs without surgery, that's 50% of the population that have a better outcome than walking around without an ACL. To me, it sounds a bit naff, but I call it a patient journey because the surgery is literally a split second of the process. It starts when they come in your room and you figure out where they are, with how far down the track of their injury they are. And we talk about expectations, what they want to achieve, what their goals are, what their vocation is, recreation, all that kind of stuff. If we decide they're going to go ahead to an ACL reconstruction, categorically they need to be appropriately prehabilitated. So they must have calm knee, 90% quad strength, and symmetrical range of motion. If they can't obtain terminal extension, they do not get an ACL reconstruction, and we'll put off surgery until they get that, because once you do the surgery, you do not get that back.
Yeah.
When they have this surgery, I have the luxury and privilege of working at a hospital where I do all my work at the same place. I have the same team, same anaesthetists, same scrubs, everything. So everyone knows their role back to front. And again, that's all about reducing variables. The patient generally gets a general anaesthetic, and they get something called an adductor canal block. So it's a block that goes down halfway down the thigh and provides pain relief to the anterior aspect of the knee, but doesn't turn off the quadriceps. So they maintain quads control, but they get good pain relief where our portal sites go in. And that the aim of that is to reduce their post-operative pain relief requirements, which means less narcotics, less
That's so cool.
drug, all that kind of stuff. And that's my anaesthetist. That's not me. Like they're pretty skilled at that kind of stuff. Patient gets a pre-prep with alcoholic chlorhexidine, which is my initial prep. Yep. They get checked by people numerous times to make sure their consent's right, make sure the leg is the right side, all that kind of stuff. I go into the bay and I say, "Hi, how you going?" We mark the leg and make sure that everything's right. Patient comes into theatre and they get set up on the table, and the patient's generally positioned supine, which means on their back, and their legs flex to about 90 degrees. And most of the surgery happens with me standing just to the side of and just in front of the leg. The leg's prepped and draped with alcoholic betadine, and you separate the surgical field from the anaesthetic field. And the majority of the surgery is done arthroscopically. So it's using computer screens all around you to look inside the knee and a camera. We reconfirm the pathology on the MRI, and we do something called a timeout, where we stop everything, everyone pauses, and we read through the consent, we read through the age, date of birth, MRN, go through their risks, make sure they've had antibiotics, all that kind of thing. And that's all just that process of making sure that we don't do the wrong thing on the wrong patient. And that's standard for every operation done all over the world. Majority of my hamstrings, majority of my ACLs at the moment are hamstring autografts. So I did fellowships in Dublin and Paris when I first came out. And the majority of the ACLs I did in Dublin were patellar tendon ACLs, and a lot of the ones in Paris were hamstrings. The decision on graft is a big one, and that's driven by what's cool at the time and also what the cultural expectations are of the country. So patellar tendon ACLs are great, but if the majority of your ACL patients are also, say, tradies and electricians, 50% of patients that have patellar tendon ACLs get anterior knee pain. So to do that to them and then have them crawling around their hands and knees for their career is not ideal. So for me, I use hamstrings for the majority of my ACLs. I also do patellar tendons, quad tendons. I use a lot of allografts, which are basically a bit of dead person. Yeah. So we get them harvested from cadavers and they're stored in freezers, or we bring them in from a bone bank.
Are they more popular? Are they becoming more popular?
I use them in revision settings only.
Yeah.
So some patients will come in and say, I would like to have an allograft. And rather than going, yes, you can have one, you go, okay, well, let's talk about the pros and cons. Let's talk about the options available, because there's so many different ways to skin a cat. And let's talk about the reasoning why you want an allograft. And the majority of people will usually want an allograft because at a time it was the thing to do in America. Or they've had a mate that had an allograft. I had one patient a couple of weeks ago whose friend had an ACL 3 or 4 years ago and had a really bad sciatic nerve injury from when the hamstring was harvested. So she was terrified of having a hamstring, and she came in going, I don't want you to take anything out of my body. I just want to have an allograft. And that's quite a reasonable thing. An allograft costs a lot of money. Yeah. So that bit of tendon's about $4,000. That's covered by most private health insurance. But if you're an uninsured patient, if you want an allograft, you've got to pay that money for that graft. And that's something that we have to consider in the world we live in, the cost of healthcare. But I harvest the hamstring. There's a small cut that we do over pes anserinus, which is the anteromedial aspect of the tibial plateau. And you cut through the deep fascia, and that gives you access to the pes anserinus. And pes anserinus is Goose's foot, and it's 3 tendons. So it's sartorius, gracilis, and semitendinosus. So the sartorius we move off to the side and we harvest gracilis and semitendinosus. And in the system I use, which is what we call a Smith & Nephew system, it's one of the companies, I create what we call a 4-strand hamstring autograft. Ideal graft diameter is between 7 and 9 millimeters. My average graft diameter is 8.5 millimeters. And that works, that's ideal. Once we've taken the graft and we're happy with the sizing, I then put a camera into the knee and do a diagnostic arthroscopy. So I look at all the cartilage surfaces, I assess the menisci, I make sure they're stable, make sure that what I'm looking at in the MRI matches what is happening in real time inside the knee. Then I go and assess the ACL rupture and confirm the pathology. But in this day and age with an MRI, you've already confirmed it. The most controversial area of orthopedics over the last 10 years has been tunnel position. So ideally, in simple terms, what we want to do is put the ACL back into its native position. And so we want to create tunnels where this patient's previous ACL was. Again, when you do a lot of these, I know that my tunnel diameter has been between 38 and 40 millimeters long every single time. And so when you do them over and over again, you've got these tiny variables. And when you drill that tunnel and you go, that's 38, I know it's the right position, I know it's all good.
Yeah.
Same thing with the tibia. So we drill a femoral tunnel and we drill a tibial tunnel. Then we pass the graft up through those two tunnels and we fix them on the femur and the tibia. And depending on which company's equipment you use, there's different fixation devices. But in simple terms, you're taking this hamstring tendon or patella tendon and fixing it to the femur and tibia and essentially recreating that ACL. And that's, I say to most patients, that's the easiest part of the process. The challenge then is the rehabilitation and recovery. And ACL grafts take a long time to mature and revascularize and get healthy and strong again. And usually between 6 and 12 weeks after surgery, they're actually at their weakest. And we talk about this thing called the danger zone, where when you see patients around 6 to 8 weeks after their ACL reconstruction, they're feeling great, their confidence is coming back. And I always talk about, the movie Top Gun, there's that quote saying, your ego's writing checks your body can't cash. It's that kind of thing where the patient comes in and goes, I feel amazing. My knee's got full range of motion. The quad's coming back. And you go, yeah, but your ACL reconstruction is not ready to keep up with you yet. And luckily the physios I work with have already said that to the patient. I go, oh, you're coming into, and they go, we know it's the dangerous part. We're being sensible. We're not going to play OzTag on the weekend with our mates. We'll keep it sensible. At around the 3-month mark, we start getting the strengthening side of things going. But once that ACL is reconstructed, we close the wounds up with dissolvable stitches. In my practice, there is no braces. So you don't put a brace on the leg because they've already got quads control because of the block. And they're usually a day procedure. And so they're discharged usually same day. The physio sees them in day surgery unit. They're given a set of crutches, which is purely for balance. So they can wait there as tolerated and they're allowed full range of motion from day one. All of my patients that have ACLs have already locked in with a private physiotherapist. They've already got an existing relationship with their physio. They've done their prehab with their physio, which means that when they go back to their physio post-op, there's already a game plan in place. And I sort of explain to patients that prehab and rehab I liken it to, say, the city to surf. I say, if you're a weekend warrior and decide you're going to run 12Ks in the city to surf and you haven't trained, your outcome's not going to be great. If you spend a month or two training in a lead up to that city to surf, your run and your recovery and everything is going to be more effective. So the time you put in beforehand results in a more effective and efficient recovery afterwards. And it's a paradigm shift to what historically we're used to doing. There's still surgeons walking around that say that physio is useless and doesn't make any difference. It's just not the case.
Yeah.
So that's an ACL in a nutshell. And then you can get all the fancy stuff, lateral loops, meniscal repairs, chondral repairs, all those kind of things. And there's a lot of variables in it, and that's why you try and make that surgery as boring as possible, because you know that even though it's boring, there's going to be 30 or 40 variables during a case that you have to deal with and manage. Yeah. And it allows you to focus more reliably on those variables and give a patient a more reliable outcome.
Yeah, like that's awesome. Hey, thank you so much for coming on. Any parting words for any of our lovely listeners, clinicians? Any advice? I mean, you've given a fair amount. It's been lovely to chat.
Look, I think the best advice I can give is that the clinical stuff that we do it can be taught in a textbook, can be taught at university, all that kind of thing. I think the thing that the area that I think good clinicians thrive in is realizing the importance of the clinician-patient relationship. So, and it might sound like a cliched thing for an orthopedic surgeon to say, but we get grief for being called Neanderthals and dragging our knuckles and bashing hammers and stuff like that. The way that the new generation of surgeons coming through treat their patients is very different to what it was 20, 30 years ago. And I think that is the same for podiatrists, for physios, EPs, all that kind of thing. The quality of your relationship with your patient will probably be the single most defining factor above and beyond anything surgical or anything manual treatment wise you do. Yep. And that relationship will transcend pretty much anything you can do with your hands. And so that'd be my biggest advice. My success as a surgeon, I think, is built largely on the fact that I respect my patients as human beings, and I try to look at my role in the context of their life, not just you're an ACL, you're a knee replacement, that kind of thing.
Yeah. Awesome, mate. Thank you so much for coming on.
Yeah, pleasure, mate. Absolute pleasure. I hope it was worthwhile, and happy chatting in the future.
Yeah, awesome.